Good morning, everybody. It is my great pleasure to be a member of this workshop, the member of organizing committee. I am Hedy Risak. I'm a diagnostic radiologist, and I work at Memorial Sloan Kettering. Chris, thank you very much for this opportunity to moderate our first session. I was looking for your title. I don't need glasses. Thank you. Chris Cogle is a professor of medicine at the University of Florida. It's also chair of our workshop, and his title is Precision Oncology, the Optimism and Pessimism from Keyboard to Bedside. Chris.
Thank you, Hedy. So disclosures, I will discuss off-label use of the drugs are listed on the screen. And I'm also a member of a scientific steering committee for Celgene's registry study for leukemia and myelodysplastic syndromes. I'm also a founder of a company called Cancer Pop, which is a cancer genetics company. So I like to start presentations, especially this clinically oriented workshop, with a case presentation. So this is one of my patients who I saw several years ago. It was a 76-year-old white woman, and she came to me with profound fatigue. There was no recent infections, so I'm just giving you the pertinent positives and some of the pertinent negatives. So on the CBC, the complete blood count, she had pancytopenia that was requiring a red blood cell transfusion. I checked her chemistry, her iron, B12, and folate. Those are the most common reasons for people to have, especially anemia, and they're all normal. This eventually led, and I didn't suspect viral infection, so I eventually did a bone marrow aspirate biopsy on this woman, and it showed dysplastic hematopoiesis, so those are basically funny-looking red, white cells and megakaryocytes, and more ominously, she had 15% myeloblasts. So normally, we have less than 5% myeloblasts in our bone marrow. These are the stem cells in charge of making all of our blood products in our body. But she had over 5%, she had 15%. Now, to be acute myeloid leukemia, you need to have 20% or greater. So she had a very advanced myelodysplastic syndrome, which is a cancer. We used cytogenetics to look at her chromosomes. She had 46 chromosomes, an X chromosome, but her other X chromosome had a deletion in it, and that deletion actually deleted out 42 known genes. We did next-gen sequencing. That's the new standard here. When we do next-gen sequencing, she had those 4 gene mutations that you see there. We also did whole exome sequencing on this woman, and we found hundreds of genomic abnormalities in this woman. And so when I go to sit down with her, I have treatment choices, the 4 of being there: low-intensity chemotherapy, high-intensity chemotherapy, allogeneic transplant, or palliative care and hospice. And so as a clinician, the clock is ticking, and you need to make a decision. And when you have 42 known genes that are missing, 4 driver genes that are found in next-gen sequencing, and hundreds of genomic abnormalities, how do we as clinicians, as oncologists, handle this? And honestly, the way that we handle that is we ignore a lot of us ignore the genomic abnormalities, and we just focus on at least the karyotype, and then the rest goes off of the clinical presentation. It's very difficult in the clinic when you've got about 12 to 30 minutes per patient to interpret this data quickly. And that is one of the main reasons why we're having this workshop today, is because as an oncologist, it's too much pressure and not enough time to be able to understand all of these gene mutations. So the schema as a clinical oncologist for decades has been you treat the patient and you look at the response. And then they come back to you with either good response or refractory disease, or they relapse at some other time. And so when they come back with relapse disease or refractory disease, you go back to your recipe book, which is based on clinical trials, and you look at what they haven't gotten, you give that to them, and you see what the response is. And so it's a very short circuit is how we practice oncology to reduce it down. But what precision oncology is proposing to do is to first map the disease, make some kind of prediction of some kind of response, then to personalize that treatment, monitor the response precisely, and then adapt the treatment. And to do this in a very iterative way. That's the grand and noble proposition of precision oncology. What we've done in the early 2000s and here in the mid 2000s is we've taken that concept and we've used a single gene, single drug matching schema, where if you have a gene mutation, let's say EGFR, you get an EGFR inhibitor. If you have an AKT mutation, you get an AKT inhibitor. And with this single gene, single drug, quite honestly, this is quite easy as a clinical oncologist to memorize this. You can have a pocket card in your coat pocket, and they're within the memorizable capacity of an average clinical oncologist's brain. But there's some ominous findings about this type of schema. And so I want to point to the Shiva clinical trial, which was published a few years ago now. This is a multi-center French study which recruited over 700 patients with refractory metastatic solid tumors. And they had 10 single gene, single drug pairs. And in short, they found three major things. Number one, which I'm not showing you on the slide, is that about half the patients did not fit a gene drug pair. Half the patients, there was no bucket for them to be treated. The second thing that they found is here in this survival curves, is that the patients that received molecularly targeted therapy, again based on single gene, single drug, did no better than the oncologists coming up with a regimen using an older recipe book of a regimen that the patient hadn't received before. So it's no better than patient and physician choice. And thirdly, the people that got the molecularly targeted therapy using single gene, single drug actually had more adverse events than the patients that got just patient and physician choice. So this is quite ominous findings, and there's been a lot of discussion in the peer-reviewed literature about the significance of this. On the US side, we have the NCI MATCH trial, which is using a similar but different schema. And we're very fortunate to have Dr. Flaherty today in this workshop present the MATCH trial and also to extrapolate forward in using computational oncology. The other overview that I wanted to give you is I want to give you the actual universe of precision oncology and where computational modeling fits into that. So there are three general flavors of precision oncology that we're testing in the clinical oncology clinics. There's in vitro drug testing. It's where you take the cells out of the body and you test it in a dish or some kind of system in the lab. That's also called ex vivo chemosensitivity testing. That's another way of looking at it. There's in vivo, where you take the cells out of the body and you put it into an animal, and you then treat animals with potential drug or drug combinations. And then thirdly is the computational modeling, which is the focus of this workshop. So the real brief, the pros and cons. With in vivo testing, the pros is that you've got an actual three-dimensional and dynamic environment where these cancer cells are going. The cons are that there's no correlation, no strong correlation yet that these animals, that the data from the animals correlates with the actual clinical response that we see in our patients. There's also a limited number of drugs. It's very difficult to set up these patient-derived xenografts or PDX models. It's very difficult, very laborious, and it's technically very challenging. And so although it's a precision oncology method, it's one that's going to take a lot of work and a lot of investment. In vitro drug testing is much older. The first reports of in vivo drug testing were in the 1950s. And the pros is that it's usually a compact assay. You're testing the cell itself. And so all of the programming that's causing the cancer is within that cell. You've got everything in it. The number of drugs and drug combinations are more than if you were to treat animals. And there's a variety of readouts possible. You can look at survival, you could look at ATP activity, metabolic activity, colony proliferation. There's lots of a variety of readouts you can look at. You can also use normal cells. You can automate this. You can have robots doing this, as some companies are already doing. And because it's automated and high throughput, it's also reproducible. And so from a regulatory perspective, being able to have a reproducible assay is very important. The cons is that there's a lot of technical failures, and there's no strong correlation yet with the clinical. And so that's actually led ASCO, and I see Dr. Shilsky in the audience here, that led ASCO to do a working group on using in vitro drug testing for precision oncology. And so in 2004, the working group came out and said, interesting technology, not ready for prime time. Clinical trials, okay. And then they revisited this topic in 2011 and came to the same conclusions. Interesting data, not ready for prime time, that being in the clinic, more clinical trial testing is needed. And so that's another reason why we're doing this workshop, is because computational biology modeling, we'd like to have it progress in a very efficient and orderly way, and aimed at getting the data that we need in order for bodies like ASCO to be able to embrace it as a clinical standard, rather than the way that in vitro diagnostic testing has done, where there's a lot of claims out there, but it took the clinical oncologist coming out and saying, wait a minute, we can't use this until it's been properly vetted. And we want to do this right with computational modeling. The big pro with computational modeling is that it's a remotely accessible assay. It takes advantage of two of the big revolutions that we've had in our society, that being mobile computing and cloud computing. And the third pro that I'm going to point out here is that it's blockchain permissible. And so we have the opportunity here to actually give some credit back to the patients that are donating the data and that are enabling us to have this technology. So I have experience in working with computational modeling companies. We've looked at retrospective data where we have these publicly available genomic data sets that we're able to download and these data sets are clinically annotated. So we can compare our predictions using computational modeling with the outcomes of patients. And one system that I use, we're able to project the genomic abnormalities into a protein network, and then layer on top of that the drug activity, and ask through mathematical modeling, looking at proliferation rates, a modeled proliferation rate, whether or not the cancer cell of the patient has the actual drug target, but then B, has all the downstream mediators needed for that drug to work and to make its effect in killing that cancer cell. And through this computational modeling, we've been able to make inferences and discover networks and pathways that we had not known before that influence a drug's activity. I'm going to skip through this and say that we've done some pilot studies, prospective pilot studies in the clinic, where we've treated patients per standard of care, but then in parallel mode have done whole exome sequencing, analyzed their data, and then compared the predictions. And so we recently looked at 50 patients, and where we've done that, these are myelodysplastic syndrome and acute myeloid leukemia patients that are half refractory and half newly diagnosed. And we've modeled their disease based off of drugs that they've received, have found sensitive and resistant network signatures. And when we've looked at how well the computer and the engineering team models and predicts compared to the actual clinical outcomes, even in a masked setting like this, our accuracy rate is about 90%. This is in predicting clinical outcomes. This is in comparison to, as a clinical oncologist, in this disease, when I administer chemotherapy, only about 40 or 50% of patients achieve a response. And so this has led to us constructing the next level of trial, which is a randomized phase 2 using this technology. We've achieved our IDE exemption from the FDA, and in going through that FDA process, I noted that the reviewers were in the mindset of single gene, single drug, and not multi-gene, multi-drug. And so that's the third reason why I felt like we needed to have this workshop, is from a regulatory perspective, there was not much guidance on how to use a more complex system other than single gene, single drug matching. And we're beyond that. Our technology is beyond single gene, single drug. So there have been recent news and some pessimism in the world of computational oncology. So the Financial Times this summer had a report on a company called Babylon, who has a app where patients can enter in their symptoms, and the app can suggest what kind of diseases might be going on. And so there's physicians that have outcried that this app was failing, and actually led to some, as I understand it, some patients that died of heart attacks because the app was not able to recognize appropriately. And then a lot of us know also about the news with IBM Watson. There have been some, so Stat News reported that there were some unsafe and incorrect recommendations from IBM Watson. This has not been fully vetted in the public, so it's difficult to say, the veracity of this kind of report, but there's already a backlash in our community, in our public, about these technologies. And a fourth reason of why we need to have this workshop, so that we can make sure that we're doing this in a responsible way. The answer might be actually the combination of precision oncology techniques, and not just computational oncology alone. That might be the answer. My group published with the University of Miami a platform where we combine a variety of precision oncology technologies. And we've done that in a series of patients and have had some really remarkable responses. So we focus heavily on patient data and the interpretation of the patient data by computers in this workshop. But I want to point out one last thing, that the other opportunity here is to improve our physician brain in order to receive the data better, and to work with computers better. And this is generally called visual thinking strategy. So let me challenge you. Who can find the vowel here? If you find it, raise your hand. Wow, very quick. Very good. Okay, I see a lot of hands over there. I'm surprised that Dr. Hisek did not pick it first, because this test was developed by psychologists back in the 60s and 70s, and it was meant to test cognitive ability. So that half of the room, you're doing great cognitively. This half of the room, we got to work on you today. Okay, you're just shy. Okay, so the psychologist who was testing this in the 70s noted that his wife was 9 times faster than every other subject that he was testing. His wife was a radiologist, and it gave him my idea, and thought that maybe radiologists are very good at picking out subtleties, and they are. That's your job, right? So this psychologist in the 70s then tested radiologists, and actually randomized a group of radiologists to do this test every day for 3 weeks, and do it multiple times, not just once like this, but to do it multiple times a day. This was their test that they had to do. And then they were allowed to read their radiologic imaging. At the end of 3 and 7 weeks, the psychologist then gave the radiologists in the 2 groups some radiology images, and asked them to pick out, to categorize them as normal, possibly abnormal, or absolutely abnormal. And what he found was the radiologists that were trained to pick out the vowel in the list of consonants were significantly better at categorizing radiologic images as abnormal compared to those that had not gone through this visual training. And then there's also this kind of training. So this is another visual training. This is done by some dermatology groups. There's a Dr. Braverman at Yale that has this kind of a course where he's taken medical students and dermatology fellows and have asked 3 simple questions. What's going on in this picture? And there's a discussion around that. What do you see that makes you say that? So where's your visual proof that supports your observations? And then what else can you find? And so as you're looking at this, when I first looked at it, I thought it was some women in snow. And then you look a little closer, these look like Hindu women, and it might be a religious ceremony. And although the answer is that these are Hindu women, and they're celebrating a sun god, they're at the banks of a river. The river is polluted with sewage. And so what they're praying for, and so these women are actually fasting, and you can see the men in the back who are separate from the ceremony. So that's the actual facts of the case, but that doesn't matter. What matters more is your ability to detect things and your ability to discriminate and you to challenge your own assumptions. So this process is going on in dermatology, and it's helped in the medical students and residents become better diagnosticians in analyzing the data that they come to. And so what I put forward is that we need to be thinking about how to train us clinical oncologists on how to look at genetic data better, and not just as a PDF file with a bunch of acronyms on it. Is there a better way to prepare us in medical school or fellowship in order to embrace the complexity of data that's put forward to us on a daily basis? To end this, my patient that I presented in the beginning chose to receive azacitidine chemotherapy. There was about a 40 to 50% chance she would respond. She did respond, and she's responded for 4 years. And that's great, and I pat myself on the back, but this feels a lot like another activity that a lot of us do, and that's playing blackjack. And in blackjack, your odds of beating the dealer are about 40 to 48%. About the same odds that I have in getting and achieving a response in my patients. And in blackjack, you could count cards, but you're not allowed to. And you're not allowed to because you could beat the dealer if you do that. And I think it's apt for this analogy where we could count cards in oncology, but it's not that we can't, it's because we aren't yet. And we are about to do so. And so when you win at blackjack, my other point is that when you walk away from that table with positive cash, you feel a little bit good that you beat the dealer, but you also feel a little reckless that you've won. And you've won by not knowing all of the facts or all of the statistics. And I contend that as clinical oncologists, we should also feel proud that we win with our patients, but also feel a little reckless unless we have all the facts. Thank you.